Hi everyone, my name's Yvette and today we're going to be talking about ovarian cancer. We'll look at the different types of ovarian tumours and then look at ovarian cancer in more detail, how it presents, what investigations we do, how it's diagnosed, and then how we manage it. There are many different ovarian tumours and this can be quite confusing, so it's useful just to take a look at the structure of the ovary and the different cell types first. So the ovary is made up of a cortex and a medulla, and the outer cortex is covered by an epithelium. And the most common ovarian carcinoma originates from this epithelium. These are called the epithelial tumours. For example, the serous adenocarcinoma. Otherwise, we have the cortex, and in the cortex there is the stroma. And stroma is just the connective tissue. And in the cortex, this is where we find the follicles. And the growing follicles, they have a few cells, for example, the theca cells and the granulosa cells. And it's the granulosa cells which usually secrete estrogen, which means that if there's a tumor in these cells, they will be secreting estrogen. Another cell type of the ovary are the germ cells. These are the primitive embryonic cells of the ovary, and the germ cell tumors will arise here. And another different type of cancer that one can get in the ovary are the metastases. An example would be the Krakenberg tumor. This is a metastasis from the gastrointestinal tract coming to the ovaries. And ovarian tumors can be classified according to the site of origin. So if they're primary, they arise from the ovary itself, or secondary when they're metastases from another part of the body. And many of the tumours can be classified as either benign or malignant, and most of them do not actually produce hormones. If they are producing hormones, then it's likely to be the stromal cell tumours, for example, the granulosa cell. And in young women, the most common ovarian tumours are the germ cell tumours, but this changes with age. Taking a look at ovarian cancer in general, it's the second most common gynae malignancy after endometrial cancer, and is the fifth most common female cancer. The lifetime risk is 2%, and the mean age at diagnosis is 64. It's got a higher incidence in white women, and a large proportion actually may originate from the fallopian tubes. It's known as a silent malignancy, which means that it tends to present late when the disease was already in the abdomen, and therefore the 5-year survival is actually quite poor at about 35%, and it's got the highest mortality among all the gynae cancers. And in ovarian cancer, the most common subtype are the epithelial cells, and of these, it's the serous adenocarcinoma which are most common. Other types of epithelial cancers include mucinous, endometrioid, and clear cell. Risk factors are associated with the number of ovulations. So things that increase the risk of ovarian cancer include nulliparity, early menarche and late menopause, factors like smoking, obesity, and genetics. There are factors which lower the risk of ovarian cancer. So being multiparous would make the woman be at lower risk. Pregnancy and lactation are also protective. The combined oral contraceptive pill, and procedures including tubal ligation, a salpingectomy, or a hysterectomy. The genetic risk is the most important risk factor for ovarian cancer. 10% of women with ovarian cancer do have a hereditary predisposition, and there's an increased risk associated with BRCA1 and BRCA2, as well as with Lynch syndrome. So we've said the lifetime risk for the general population is approximately 1 in 60. If one family member is affected, the risk can increase to up to 1 in 20. And it's BRCA which accounts for 90% of the hereditary cancers, the biggest contribution coming from BRCA1. And if a patient has BRCA1, the lifetime risk of developing ovarian cancer can be almost 50%. With ovarian cancer, the symptoms are often initially vague or even absent, so 70% present late at stages 3 and 4. But most commonly, the symptoms are a persistent abdominal distension, so bloating, feeling full or a loss of appetite, and urinary symptoms like urgency and frequency. There are other symptoms which may come a bit later, including pelvic or abdominal pain, a change in bowel habit, so always bear that in mind as a differential diagnosis to IBS in an older woman. The woman may complain of back pain, fatigue, irregular bleeding, and even dyspareunia. The first thing to do is examine the lady, and the examination may reveal ascites or even an abdominal or pelvic mass, which would be fixed and hard. And in primary care, the first line investigation would be to request the CA125, which is the tumour marker for ovarian cancer. And this would certainly be indicated in a woman who is over 50, who's presenting with any of the symptoms above, including things like bloating, loss of appetite, etc. And if the CA125 is raised, so that's above 35 international units per milliliter, then an urgent ultrasound of the abdomen and pelvis must be performed. If the ultrasound or the examination reveals a mass or ascites, then there needs to be an urgent referral, which means that if the examination alone reveals ascites or a suspicious mass, you can bypass the above investigations and just send them directly to gynae urgently. In secondary care, if the CA125 hasn't already been done, then that must be performed, and an ultrasound must also be performed, and it's the transvaginal ultrasound, which is the modality of choice. And it's important to bear in mind that if the woman is under 40 years old, other tumour markers must also be requested. So examples would be the alpha-fetoprotein and HCG, and these identify the germ cell tumours, so the non-epithelial tumours. It's also important to note that CA125 is not specific for ovarian cancer, so it's also raised in conditions including endometriosis. It can be raised in pregnancy and in alcoholic liver disease. And on ultrasound, there are certain features that may suggest that the mass is likely to be malignant. So a mass that is rapidly growing or it's over 5 centimeters, that is worrying. If there's ascites on ultrasound, if there are bilateral masses, and if the masses have a solid nature or a septate nature, these are all worrying features. In ovarian cancer, we calculate the risk of malignancy index, the RMI, and this gives us a rough idea whether this could be cancer. So for the RMI, we look at a score from the ultrasound. We have the M score, which is the menopausal status, and the serum CA125 level. So in terms of the ultrasound score, it looks at the different characteristics. Worrying characteristics will score points. Things like multilocular cysts, solid areas, metastases, ascites, if there are bilateral lesions. And if there's one of these characteristics, then the score is 1. If there's more than one of these characteristics, then there will be 3 points here. So that's the U score. And then the M score is the menopausal status. So it's 1 if the lady is premenopausal, and it's 3 points if the woman is postmenopausal. And you also, as we said, we multiplied the serum CA125 level. And the lady would be referred to a specialist MDT if the RMI is above 250. We follow the FIGO staging, and there are 4 stages in ovarian cancer. Stage 1, so the earliest stage, is when the tumour is still macroscopically confined to the ovaries, where 1A is with one ovary being affected and the capsule of the ovary still intact. 1B, both ovaries are affected, but the capsule is still intact. And in stage 1C, either one or both ovaries are affected, but either there's tumour on the ovarian surface, there's a ruptured capsule, or there are positive washings. So there are malignant cells found in the ascites or the peritoneal fluid. In stage 2, the tumour is now spread a little bit, but it's still confined to the pelvis. So it could have spread to the uterus, to the fallopian tubes, or to other pelvic tissues. In stage 3, the tumour has spread to the abdomen, or the lymph nodes are positive. It may have spread to the small bowel, to the omentum, and to the peritoneum. And this is the most common stage. This is where most women present. This also includes where cancer cells are found in the liver capsule, so the surface of the liver. Where stage 4 is the disease has spread beyond the abdomen, so it's distant metastases, including to the actual liver or to the lungs. The management depends on the stage of the cancer. So stage 1, very early ovarian cancer, the first line is surgery, and this is done both to fully stage the disease and to remove all visible tumour. So it's both diagnostic and therapeutic. It's a midline laparotomy, so a vertical incision, and the procedures include a total abdominal hysterectomy, bilateral salpingo oophorectomy, with an infracolic omentectomy, so partial removal of the omentum. We would also sample the retroperitoneal lymph nodes and see if there's cancer cells in the lymph nodes. And usually adjuvant chemotherapy is not routinely offered at this stage. In advanced disease, so stages 2 to 4, ultra-radical surgery is performed. This is sometimes known as complete debulking. So it's also a laparotomy, like in stage 1, and the same procedures are also carried out, as well as bowel resection, splenectomy, peritoneal stripping. It really depends on where the tumour has spread to. And the aim is to leave no tumour deposit that is larger than 2.5 centimetres. As well as this, a systematic retroperitoneal lymphadenectomy will be performed, so block dissection of the lymph nodes, and adjuvant or neoadjuvant chemotherapy, so chemotherapy together with or before surgery. In terms of follow-up, we monitor the CA125. This tends to rise before the clinical onset of recurrence. CT scans can also be performed to detect residual disease or relapse, and interval debulking surgeries can also be performed to remove any residual tissue. And the most important prognostic factor would be the advanced stage of the cancer. Other factors which are important include high-grade tumours, clear cell or papillary subtypes of the tumours, and a slow or poor response to chemotherapy. Death usually occurs due to a bowel perforation or bowel obstruction. And overall, the 5-year prognosis is quite poor at about 35%. If the disease is caught early, so at stage 1, then the survival can be up to 90%. But in the majority, at stage 3, it's about 30 to 40%. And here are the key points from the tutorial. So we've said that ovarian cancer is the leading cause of death from gynae malignancies in the UK, and it's known as the silent malignancy because it tends to present late with vague symptoms. And in terms of treatment, surgery is the mainstay. And that's the end of the tutorial. Thanks so much for listening.